Thomas Gallagher is a general internist who is a professor in the Department of Medicine at the University of Washington, where he is Associate Chair for Patient Care, Quality, Safety, and Value. Dr. Gallagher has published over 120 articles and book chapters on patient safety and error disclosure, which have appeared in leading journals. He is also Executive Director of the Collaborative for Accountability Improvement, an organization dedicated to advancing the spread of communication resolution programs. In 2017, his work advancing communication resolution programs was recognized with the receipt of the John M. Eisenberg Patient Safety and Quality Award for Individual Achievement, presented by the National Quality Forum and the Joint Commission. This webinar is sponsored by the Collaborative, and I will now turn it over to Tom. Thank you very much.
Thanks, Steve. And can you hear me okay?
I can hear you.
Perfect. Well, it's wonderful to be on with all of you. As Steve mentioned, I'm Tom Gallagher, Professor and Associate Chair of Medicine here for Quality and Safety, and lead the Collaborative for Accountability and Improvement. And this webinar is one in a series of activities for the learning community that the Collaborative is developing in partnership with Ariadne Labs, which is a joint program of the Brigham and Women's Hospital and Harvard School of Public Health in Boston. So it's great to have you all here. We're used to, when we think about communication and resolution programs, we're used to thinking about individual adverse events. Individual adverse events, I mean adverse events that have affected an individual patient. But one of the goals of the Collaborative is to really broaden everyone's horizon to think about the importance of transparency in the setting of adverse events more generally. And today we're talking about that broader topic of how do you respond when an adverse event has affected more than one patient, sometimes hundreds or thousands of patients. So our objectives today for the webinar is that we want to describe the diversity of large-scale adverse events and how responding to these events is different from managing those events that affect individual patients. Think through the different elements of an effective response to a large-scale adverse event and what tools are currently out there. And then actually look at an actual large-scale adverse event patient notification letter and press release, and think about opportunities for improvement in those documents. And as part of that, I hope all of you got some of the background material that we emailed to you for this. It includes an article that we wrote on large-scale adverse events that was in the New England Journal that you can put aside and read if you're having trouble falling asleep tonight. But what you really need in front of you for the webinar today is a document that has two exercises on it. One is exercise 1, written notification, and the second is a press release. So if for some reason you didn't get that email and don't have those documents, just shoot Steve Levy an email or note in the chat what your email address is, and we'll send those to you midstream so that you'll have them when we are thinking about those exercises a little bit later in the webinar. Well, I hope all of you are having a good day today. If you had been in your role at Duke Health System several years ago and recognized that this had happened, you probably would be having a bad day. It turned out that the same company that was taking away used hydraulic fluid from the elevators in the parking garage was also the same company that was delivering sterilizing soap to Duke's operating rooms. And both of those liquids, the used hydraulic fluid from the elevators and the sterilizing soap, were in somewhat similar looking 50-gallon drums. And you guessed it, the company was meant to drop off a 50-gallon barrel of sterilizing soap and instead dropped off one of these barrels of used hydraulic fluid. And the surgical staff started to complain that their instruments felt slippery. and it took a little while to realize what the problem was, and you can then imagine the challenges of trying to figure out how to respond to an event like this. We're going to circle back to this particular case in just a few minutes, but I did want to remind everybody of the sort of the general context of communication and resolution programs, because the different elements of the CRP response listed here on the left-hand column of the slide are relevant whether it's an adverse event that affects an individual patient or multiple patients. Early incident reporting, open communication with the affected patients and their families, and we're going to be focusing on some of the challenges of that communication when it involves multiple patients. Careful event analysis and quality improvement with a focus on system solutions. Financial resolution and making those offers proactively when patients have been harmed by errors, care for the caregivers, and then patient and family involvement. And as I mentioned at the outset, this is really just one of a host of transparency practices related to adverse events. All of us focus on what do we say about the event to the patient and family, but there are a broader set of issues that we want to at least keep in the back of our minds, and we'll be talking about more down the road in future webinars. How do we make it easier for patients and families to speak up when something has gone wrong? How do we talk about our colleagues when there's been an adverse event that we've been involved in? How do we make it easier for organizations to talk with one another about adverse events? And then the topic of the webinar today, how do we respond to these large-scale adverse events? So large-scale adverse events are similar to individual adverse events in a couple of ways. The types of these events, their causes, and their severity can really vary widely. And we're going to have a chance to talk about some of that variation today. When it comes to large-scale adverse events, if you look at the paper that we sent out, there's actually a two-page table that describes the whole host of different types of large-scale adverse events that can happen, and the list has broadened considerably since that article was published a couple of years ago. So large-scale adverse events are like individual adverse events in the variation in their type, cause, and severity. And there are very strong patient expectations that there will be openness when these events happen, as well as learning. There are some important differences, however. By definition, large-scale adverse events involve multiple patients, sometimes thousands or even tens of thousands of patients. So it's very, very difficult to keep these events quiet. There's a very high potential for these events to have a negative impact on the reputation of the organization. And I don't want to suggest that responding to individual adverse events is not resource intensive, but responding to these large-scale adverse events and doing it appropriately can be highly resource intensive. But I think one of the takeaway messages of our webinar today is that investing those resources in an appropriate response, both in planning for these types of events, and then when occurs, being ready to really respond effectively is well worth the investment. One of the other major differences from individual adverse events is that many large-scale adverse events, at least for most of the patients that they have affected, represent near misses, meaning you've identified a process breakdown that potentially affected a large number of patients. But you don't know whether or who those affected patients are until you've done some sort of an investigation. And you can't oftentimes do that investigation unless there's been some notification of the patients, and they can come in, at least in some of these cases, for testing for things like bloodborne pathogens. But there's been an enormous amount of concern, given that for at least some of these events, the vast majority of patients will be unharmed, that perhaps we're causing a lot more harm than good through the anxiety associated with the disclosure itself, as well as the related concern that if we tell patients about this large-scale adverse event, most of whom were not harmed, is that going to lead to a loss of trust that may prompt patients to avoid needed follow-up care down the road? But let me give you a specific example. This was a case that occurred at the University of Washington Medical Center. This was several years ago. And there was a breakdown in the process of cleaning endoscopes. There was a multi-step process for cleaning, and one of the steps, due to a computer programming error, was significantly shorter than it should have been. And so UW had a dilemma on its hands. They thought that roughly 600 patients or so were affected by this exposure, meaning they had an endoscopy that was using one of the not fully cleaned endoscopes. When the ID folks and infection control folks looked at the exposure, they actually thought that because all but one of the cleaning steps had happened as intended, the risk of infection from the incomplete cleaning process was thought to essentially be zero. So there was basically no increase of being exposed to a bloodborne pathogen that would be any higher than that normally found during the procedure. But the medical center worked extensively to understand what happened, filed a report with the FDA and the Washington State Department of Health, and made a decision that they were going to go ahead and notify patients who notified by letter within a few weeks of the problem. And this was really a useful opportunity for us to try to answer one of those questions that was really dogging the field that I mentioned earlier, which is, if we reach out to these patients and let them know of this exposure, is it going to do more harm than good? Is that consistent what patients and families want? And so a couple of years after this event, we conducted a survey of the patients who received the endoscopy notification letter. And we were able to reach out to 127 of 266 eligible respondents. This was a couple of years after the exposure, and so the number of patients who were eligible to return the survey was less than the number who had originally received the notification letter. And the survey it asked a few questions first, and then included a copy of the notification letter for anyone who might not have remembered what was said. But it was overwhelming that folks thought notifying them of this problem was the appropriate thing to do, although almost 2/3 said they were somewhat or very concerned that this endoscope cleaning problem might cause healthcare problems for them. The impact of the notification on the perception of UW's honesty and integrity, 94% was either increased or unchanged. The impact of the notification on the perception of the quality of care provided, interestingly, 30% said the notification increased their perception of the quality of care. Roughly half said no change. So almost 80% of the respondents thought the notification had either a positive or a neutral impact on the quality of care that they received. So I think, at least for this type of exposure, we were able to pretty definitively answer the question of whether notification was consistent with what patients wanted. And we didn't provide the data here, but the vast majority of patients responded and would recommend similar notification if another event were to happen in the future. Well, let's actually move on to our second case. And we're going to spend a little bit more time with this one. This was another case of a breakdown in infection control processes. And this was a multi-specialty physician clinic where 2,000 patients were potentially exposed to a fungus called acremonium due to a breakdown in the disinfection process for these endoscopes that were used for ENT procedures. Acremonium is a fungus that has relatively low risk to immunocompetent patients, but does pose a risk of invasive disease for patients who are immunocompromised. So the clinic in question immediately notified the affected patients, and they used a multi-pronged strategy that depended on whether or not this was a patient who had positive cultures for acremonium. Those patients got a personal contact from their clinician, and then written notification of this was provided for other patients, and that written notification was further customized depending on whether or not this was a patient who was known to be immunocompetent or immunocompromised. A dedicated hotline and clinic for acremonium was set up. The organization worked in close collaboration with local public health officials and actually developed and disseminated a press release that you'll have a minute to that you'll be able to read and review in just a minute. Here's our first exercise. So take the letter, and up at the top it should say of the document, it should say Exercise 1, Written Notification. I want you to imagine you're at home and you got this letter in the mail. If you haven't read through the letter yet, we're going to take a minute and I'll let everyone read through it. And then we want to talk about what about this letter you liked and what about the letter you would have phrased a little bit differently. Why don't we wait just a minute, and then Steve, I'll give you the signal to unmute folks' lines so that we can start hearing some thoughts about this.
Great, thank you, Tom.
This is going to be a little bit of an experiment because oftentimes when we do webinars like this, we're not able to sort of be as interactive as we would like, but let's give this a try. So for folks who have had a chance to look through the letter, let's start with what you liked about the letter. Who'd be willing to chime in and share a little bit of what you liked?
All lines are unmuted now, so if you're not talking, if you'd be willing to mute your line, that'll keep the noise down. The letter itself will not be on the screen. It was a handout that was provided through an email. If you did not receive that letter, we'll be happy to send it to you. Just chat me, please.
Hi, so this is Jessica Yanni Moody. One of the things that I really liked about the letter is right away up front, there is an expression of regret about this potential exposure. So right away we're saying we're sorry about this. And the one thing that I was thinking maybe that could have been phrased a little differently, or if possible, it just feels a little vague. It says like we're on the end, we place a high priority on patient safety and we'll continue to improve our processes. But I think as patients, they maybe would want a little bit more about what exactly it is we're going to do, if that was possible.
Those are, yeah, both great observations, Jessica. And let's stick with your first one initially, and then we'll loop back to your second in just a moment. You noted that there was apologetic language right at the outset, and I would say, and we've helped organizations with lots of these different letters, and that can be a bit of a struggle to get organizations to put apologetic language right at the front. Oftentimes they wait until the very end. Jessica, do you have any speculation as to why organizations sometimes are hesitant to lead off with apologetic language?
I think that naturally organizations feel a little bit defensive and feel as if they apologize, they're admitting wrongdoing. But really, as a patient, I just want to hear that you're sorry that this just happened to me. You know, it's the same with an airline. I want to hear that they're sorry my luggage got lost. I understand it's a complicated system, but care about me as a person.
That's great. What do others think about this point regarding the issue of apologetic language right at the front? Do you share Jessica's sense that that was helpful, and why do you think organizations often hesitate to do that?
This is Tom Green. I think it's helpful. I think it's good that they do it. And I think they hesitate to do it because it sort of conveys a notion of liability.
That's great, Tom. Thank you. Others' thoughts about the issue of apologetic language right at the outset? Don't be shy. What do people think about Jessica's comment that the information in the language in the letter was a little bit vague, that when you read the letter from the perspective of a patient, you had some trouble figuring out exactly what happened here? Jessica pointed out the language suggesting that we, at the bottom, will continue to improve our processes. Did you have a clear sense of exactly what happened and what are they doing to fix it after reading this letter?
I would have changed, this is Brittany, I would have changed the order where you start with what is the impact to me. Wouldn't you want what happened to go first and then how that impacts them? And then what they can do?
So Brittany thinks the order might be a little bit off. What do others think?
Yeah, this is Dawn. I'm not sure how I feel about that. I mean, I think it could certainly be switched without much, much impact. I did like the, in that section, the impact, we've consulted with national experts and the experts agree. I mean, that would make, I think, a patient feel like, okay, this is not just a work on it. I think the other piece to, as a person with experience and stuff like this, speaking from experience, the comment about wanting to know more about what processes have changed, it might be challenging to figure out how to do that, and not overwhelm the patient with all this information. Like, we've changed our cleaning procedures and our dry, it just might, I could see how trying to be a little more succinct and then leaving a phone number saying, well, I want to know more about what you've done to change it might be a way to handle it. But I could kind of see it both ways, about providing too much information and overwhelming somebody versus just trying to give them, the basic facts and some resources.
Great comments, Brittany. Oftentimes the feedback we hear about letters like that, not this one in particular, but in general, a challenge is to avoid them coming off as legalistic, as sort of preparing for a potential lawsuit. Did folks feel that this letter was, did it have a legalistic feel to you? And if it did or didn't, maybe you can say a little bit about why.
Yeah, this is Marcia Broth. I actually had a different comment if I just wanted to stick it in. I agree with the comments earlier about the order, and I agree that it could be more succinct. I thought a lot of words to explain something that wasn't really that complex. The other thing I would say is that this is not written at a 5th grade reading level, and we probably should have been thinking about more simplified language. And if you're doing a large scale disclosure, you have to also think about all the people who are not, where English is not their first language, and you probably should have included taglines on it so that you could make sure that people knew that there were translated versions of this document available.
Really good suggestions, Marcia. Thank you. Did anyone want to weigh in on the issue of whether this had a legalistic tone to it before we move on to the next exercise?
This is Renee over at the Mutual, and I don't know about legalistic, but I definitely agree with the caller who mentioned that this isn't at a 5th grade level. It does get on par with, I think, being too complex and too much language for the average person. And so, I mean, maybe that feels legalistic to the average person reading this document. And the other thing is, under what should I do, the first sentence is your risk of infection is extremely low. I might have opened with that up under what is the impact to me, and I think patients do want to know pretty quickly what is, why is this important to me, equally as much as what happened, but probably more so like, what does this have to do with me? That's all.
That's great, Renee. Thanks so much. And Steve, maybe we can mute the other lines for just 1 second. There are a set of notification best practices that are emerging, and we'll circle back to these in just a moment. It depends on the harm for patients who are either experienced or at risk for high harm. I do think personal notification by the clinician followed by written notification is appropriate, but you really need to prep those clinicians to conduct these discussions effectively. I do think for low harm events, written notification is appropriate, but as you're hearing, you really want to get lots of input from folks on how to phrase these letters appropriately. Towards the end, I'm going to ask Marcia if she can weigh in a little bit more on some of her experiences with what are the resources needed for really a robust response to large-scale adverse events. I would just highlight that, you need to anticipate that there may be some patients who have, I would call it a PTSD-like response. And these are not necessarily patients who have had a prior diagnosis of mental health problems. And it manifests itself oftentimes by repeated requests for testing. They get tested, they're negative, they still are worried, they want more testing, and those are situations where you want your mental health providers to be able to step in and assist you. For the really large-scale notifications, you just have to expect that that testing is going to uncover some cases of either Hep C or HIV that appear to be new. And for those cases, even if you think the probability of the patient having contracted a bloodborne pathogen from the exposure is extremely low, if they were Hep C and HIV negative before and after the exposure they're now positive, you really sort of own those cases. And then as we'll talk about more later, I think what we're learning in the field is that the more proactive the media strategy, the better. And you need to, as part of that, assume that the written notification is going to be public and write it accordingly. We've already heard about the importance of clear and direct language. I think apologizing explicitly and more than once is helpful as part of this process. It is a balancing act to figure out how much information are we going to include in the letter, but I do think patients care about knowing some specifics, not all, but some specifics about what are you going to do to prevent recurrences. And then one area that can be difficult is to know whether or not to make a recommendation regarding testing. Sometimes people react to these letters and think, well, I don't quite get what happened here, or I don't quite get what am I supposed to do. It says if I'm interested in more information or I have questions, here's a number that I can call. But for those situations where you can actually offer a recommendation for testing or that additional testing isn't required, I think specificity around those next steps is extremely helpful. So let's move on to the second exercise, which is looking at the press release from this same event. It says up at the top, exercise 2 press release. Why don't we take 30 seconds and folks can read that, and then we'll talk a little bit about it before we move on and quickly talk about some of these other cases. So what did folks, and Steve, maybe you can unmute folks' lines, and it's helpful if individually you can mute your line if you're not talking. What did folks think about the strengths and the opportunities for improvement in this press release? Let's start with what you liked.
All lines are unmuted.
This is Jessica Yanni-Moody, EWMC. I like that we confirm what we learned in the review and then specifically what's going to be done about it. I think if I went with things that could be improved, I think it's the same thing. It's at a very high reading level, and I'm not seeing an apology in this one.
Interesting, isn't it, Jessica? No apologetic language in the press release. Would you have recommended that they include some?
I would have. I think if you look at the mission of, right, our mission is to improve the health of the community, and so we have this responsibility. I think it's important that we would apologize to, you know, all of our patients.
What did other people think? What did you like about the press release? What might you have done a little bit differently?
So this is Kathleen. I would say there are a couple of things. I think that the press release is generally more clearly stated than the letter. But there are some things, and then it refers to TEC. There's a little bit of confusion.
So generally clearer than the press release, than the written notification, but some areas that you found a little bit confusing. What did other folks, any feedback, things that you liked, things you might have done a little bit differently?
Hi, this is Dawn. I agree with some of the comments. I think the thing that struck at me that seemed confusing and maybe inaccurate or not necessarily something people would even understand is the comment. There's a statement that says acrimonium is no longer present at the clinic. It just seems like a strange statement to make for an organism that's ubiquitous in the environment. And I don't know, I mean, it could have been that it was written by maybe marketing and communications professionals, but I think there's just some language in here like that it's a little higher level. That was confusing to me and potentially conflicting with just, it's not necessarily something you could actually state that's accurate. So that was my one critique.
Yeah, that's great. One or two more comments. What do people like about the press release? What would you have done potentially a little differently?
This is Brittany. I would say that, you know, the paragraph that starts with still the clinic believes that patients should know, right? If you could move that to the top, like right under that first sentence and say something more of
proteins. And don't
that
forget to drink plenty of water. For more information on how to eat healthy and stay
Hello?
well, kp.org.
There we go. Thank you.
I would have, that way you're starting with the apology a little more, if you're trying to find one in this paragraph, move that up and say, you know, although the risk is low, we find it necessary to inform all people of their healthcare kind of deal. That way you're starting out saying, because I think starting out with it's commonly found in this environment and that basically saying it's no big deal, it also subtracts from you know, we take all things seriously.
Yeah, that's great. And I think both the feedback on the written notification and the press release just highlight how helpful it is to get input from as many folks as possible. These written notifications, either the letters or the press releases, are very difficult to craft. In this particular case, even though this was a very widespread event, lots of patients affected, there was a one-day story about it in the local paper that concluded with a quote from the county public health official that said, "I think the clinic has handled this event appropriately," and that was the end of that. So really, the organization did a really nice job of responding to this. So we're going to now go through in a rapid fire sort of way. So let's leave the lines open. A couple of other large-scale adverse events. And I want you to think about kind of what's different. The first two cases we had were all infectious exposures. What's different about some of these cases we'll consider now? Let's go back to the Duke hydraulic fluid mix-up. Used hydraulic fluid from the parking garage elevators was substituted for sterilizing soap. Operating room equipment was all slippery. What's different about this case in terms of thinking through how you might need to respond?
So this is Jessica, and if I'm looking at this article from a patient perspective, I think the first thing I'm thinking is, wait, what does this mean to me? What does this mean for the surgery I've had? What should I be looking for? And the second question that popped in is, how can this even happen? And how could there not have been checks if I was looking at this from a patient perspective?
And both comments are great. I think, you know, the colonoscopy cases, and to some extent the acrimonium case, they both have a little bit of what I would call the ick factor. You read about it and you're just like, ooh, you know. This one, I mean, people imagining, you know, hydraulic fluid coating the surgical equipment that's being used in their operation really has sort of the ick factor. But it's difficult to know exactly what the exposure means. And Duke actually struggled because the manufacturer of the elevator fluid would not share the material data sheet with them. So they, you know, had difficulty figuring out exactly what the health risks associated with exposure were. So in this case, you know, I think from the patient perspective, it can be harder to figure out how in the world could this have happened? What are the implications to me? I think that means that the communication needs to be even more robust. What else do people notice about this event, this type of event, as being different from the first two cases that we considered?
Tom, this is Steve. I have a question about this event. The last paragraph says that hospital officials said they could not give information to anyone while the investigation was going on. With CRP, we're supposed to, you know, encourage transparent and ongoing communication. How does the timing of this work? Is it appropriate to avoid, you know, the misconception that, you know, we're waiting to be public about this while the investigation goes on, or, you know, how do you work the timing of release of information?
Well, this was very tricky, Stephen. You can see from the date, this happened, you know, almost 14 years ago. And I think that Duke, to their credit, really did an outstanding job of reaching out to the affected patients and trying to inform them of what happened and be as supportive as possible. They struggled trying to figure out how much of that process to make public. And this article, I think, in part was a reflection of that. I think part of their struggle was around what I just mentioned, which was they really had difficulty getting definitive information on what the exposure was, and they didn't want to release information that was incomplete. So what advice do folks have in the CRP era? If you were giving Duke advice, would you have been releasing more information publicly about the investigation as it was going on, or wait for the investigation to be complete?
This is Marcia Rose. I would definitely want them to be giving information as it was going along. And I know one of the strategies we found useful in at least one infectious disease outbreak was to send communications to the staff internally, and then those were released to the press as an ongoing media relationship. So that way we knew absolutely that what was being communicated internally and what was being reported externally would be consistent. And it's particularly important for us because we're a public entity, and it's really not uncommon to get public records requests for these types of things. So that worked really well.
I would agree with that.
It's not a, go ahead.
I would say I agree with that, Marcia. I think, you know, especially when system-wide things like this happen, and we talked, I like that you brought up and said the ick factor, right? That's so true. This one just, that hits home a little bit more, and it just feels so much like trust is broken between healthcare and the community. And I think being transparent is one of the ways that we can start to repair that break in trust.
Mm-hmm.
And one of the reasons why that internal communication with all the staff is so important is that this is in the paper, and you can imagine if you're a Duke employee and you're in the grocery store and one of your neighbors runs into you and says, hey, what's the deal with that hydraulic fluid thing? You want, you know, all of your employees to at least have a little bit of basic knowledge so that they could respond effectively, because a lot of the communication is through these formal channels, but a fair amount is informal. Okay, let's move on to the next case. This is a case I call DriveBy Colonoscopy. You're a risk manager at a large multi-specialty group practice. You're reviewing a lawsuit filed by a clinic patient claiming delayed diagnosis of colon cancer. The patient had been complaining of rectal bleeding and abdominal pain for 6 months, which prompted one of your GI physicians to undertake a colonoscopy that showed only hemorrhoids. The GI physician recommended a high-fiber diet, but the symptoms persisted. The patient began to lose weight. She went to a different provider outside your clinic, got another colonoscopy, and it revealed metastatic colon cancer. Once you got the claim, you then start to review the chart and realize that the time from insertion to removal of the colonoscope was only 8 minutes, and start to look at some of the other charts from this physician, who happens to be one of your clinic's biggest revenue generators, showed that all of his screening colonoscopies were much shorter in duration than recommended. So what's different compared with our 2 infectious cases and our hydraulic elevator fluid case? What's different about this large-scale adverse event?
Deviation of physician practice.
So this is the hydraulic fluid case, the sterilization cases really are system breakdowns. This case involves poor care delivered by an individual provider, but over and over again to a population of patients. What else is different about this particular case?
We know that, hi, my name is Betty, and we know that there are patients that definitely are impacted by this.
There are definitely patients who are at risk, and the potential for harm is significant. That's great. Somebody else had a comment?
This is Jessica. I was just saying that, you know, when we look at the other ones, you know, the hydraulic fluid was mixed up. There was a break in cleaning process. This is system. It was multiple people making these mistakes within this system over and over. This sounds like it's specific to one clinician and the way that they're practicing. And so I feel like there needs to be a lot more investigation here as to why this particular clinician is using a much shorter duration.
Great. Other comments?
Well, one of the things that concerns me about things like this is that the physician being one of the larger producers seems to generate a conflict. Like centers tend to ignore deviations from acceptable practices because of the financial benefit the person is to the organization. And I think that's a potential conflict.
It's a real challenge, and I think that was Tom who made that comment. We've got a really a complex political dilemma on our hands. There was the ick factor in some of the other cases. This case really is about an individual provider who's way below the standard of care. Before we move on to the next case, what do people think? Does this clinic have an obligation to reach out to all of the other patients that this doctor has screened? Or would you do it based on those colonoscopies where you review the chart and they appeared to be shorter than recommended in duration? What would your approach at a high level be to notification? Or, and this was actually a case I was consulted about several years ago, I recommended that they reach out and notify all of the affected patients, and the organization declined. And so sometimes organizations feel like notification isn't appropriate. For this case, what do you think this organization should do after they really do the deep dive investigation that I think Jessica mentioned? Do they need to reach out to all the other patients?
Yes.
Yeah, I agree. If we're saying it didn't meet the standard of care, then that, yeah, absolutely.
Yeah.
There's a high risk here, unlike another thing that's different about this compared to the other cases. The risk of people who are involved is fairly low. The risk here is potentially very high.
And would you guys be prepared to issue a press release about this case? Or would you stick with notification and offering to pay for a repeat colonoscopy on this physician's patients, but not approach this as an event to proactively do a press release about?
This is Marcia Rhodes. I think we would probably not do a press release on this, but we would reach out individually to patients, because the reach out so much includes and let us help you understand what this means for your personal health care, and that's going to vary person to person.
And Marcia, keep going for just a second. What would the rationale be for not doing the press release?
Well, I don't think we would. This is me personally. And we make these decisions as a group, multidisciplinary group from different perspectives. But what I would be worried about is that for patients of this doctor who's, say the colonoscopy, we looked at it and we felt that it lasted the appropriate amount of time, we'd be perhaps creating a lot more worry from patients who would not be affected. And when you have a large scale disclosure like this, you need to have people available to answer phone calls and to put people at ease. So you have to think about it in terms of what your resources are to actually answer patients' questions. So if you cast too wide a net, you run into the possibility that you won't be able to respond to the onslaught, if you will, of people who
This is Jessica. I agree with that. I think, it is a careful balance between we want to be transparent and we want to build our trust with the community, but, what is it that is necessary and what is it that is not necessary, meaning we don't need to set people's hair on fire. This isn't necessarily this huge, large scale. And I think when it comes down to the individual provider's practice, that there are other mechanisms through which these standard of care issues can be reported.
Let's just consider one additional case which has some of the same elements, and then I'll ask Marcia to share some of her thoughts about handling these events, and then we'll wrap up. So this is a diversion case. You're the risk manager assigned to the interventional radiology suite at a large community hospital. A tech was observed on at least 2 occasions swapping fentanyl syringes that were intended to be used on patients. In one instance, the swab syringe was tested and found to contain saline. On 3 occasions, empty syringes labeled fentanyl were discovered in the staff bathrooms or changing rooms for this unit. The tech was also noted on several occasions to be in the procedure room she was not assigned to and to take frequent breaks. She received formal counseling, and following the most recent episode was terminated. She did voluntarily submit to testing for bloodborne pathogens, which was negative. Throughout, she denied any wrongdoing. A review of the injection procedures in this suite concluded that the chances of cross-contamination from one patient to another were thought to be virtually impossible. So the issue at play here again is whether we need to notify all of the other patients, all the patients who have been in this interventional radiology suite that could have been affected by this tech. What do people think? Would you be in favor of notification, or is this a case where the harms of notification would outweigh any potential benefit?
Tom, this is Marcia. Did you want me to comment, or?
Well, let's hear what some other folks think. I'm making all of your heads hurt.
This is Jessica. I think on this one, and I'm trying to put on my patient hat, but it's always curious what our patients want to hear about. And when I put this on and think about it, I feel as if, you know, there's so much information and so many things that you have to kind of worry about. What would be the intent of telling me a patient about this? If there was virtually impossible, I mean, it's not uncommon. You hear in the news, we know it's a national problem about opioid addiction and drug diversion. So I guess I would just be curious what would be in it for you to tell me this information and make me worry about yet another thing in healthcare when I'm already worried.
And that's a great point, Jessica. One of the things that we're trying to encourage people to think about is that transparency isn't a goal in and of itself. Transparency is good, but it really is a good to the extent that it contributes to other more important goals: advancing quality and safety, promoting patient trust and experience. Transparency for its own sake, I think, can sometimes lead us in the wrong direction. And this may be one of those cases where transparency, just to sort of be open, actually the burdens for patients might outweigh any potential benefits. I actually wanted to take the last couple of minutes and just see if Marcia would be willing to walk through a few of these suggestions that she's learned over the years of managing these types of large-scale adverse events, and then we'll wrap up. And Marcia, thanks so much for sharing some of these ideas. Marcia?
Sorry, I needed to unmute myself.
Yes.
So several of these suggestions are things that emerged from the recent data exposure event that it was in the press about the university. We had about close to 1 million patients whose information was exposed to the internet. It wasn't actually accessed, and it included 2 elements of PHI, a name and a medical record number, but no actual diagnosis information. And essentially, point of database information that was exposed to the internet and resulted in our need to do a mass disclosure. And that was we've had other large scale disclosures, but this was the biggest that we've had to manage. And we certainly did have a external body that helped us. We had information on our website, which is of course required, especially by the state of Washington. And we had an initial setting, but we needed a backup to that. And I had the pleasure of coordinating our patient relations folks who were going to be managing the call center for the escalated calls. So one of the things we did was establish a kind of a virtual command center. And I think if we were to do it again, we talked about really doing an in-person command center daily, but we did it virtually this time. I think we would have benefited by looking eyeball to eyeball to handle emerging issues as they were happening. We did establish a clear escalation share drive so that as calls were escalated, I could send them out to each in a work queue, excuse me, for each of our patient relations teams. And I think the other thing that we did was make sure that we were communicating to our boards and leaderships regularly as the matter was being managed. Excuse me a moment. The other thing that we did, since we have multiple sites, is that we had on our share site a script and also a resources page. So we had many different types of, sorry, excuse me. We had many different types of information. We also used this, we had a drug, I'm so sorry. I had a drug diversion event a couple years ago where we did this as well, having scripts so that we made sure every patient was getting the same answer to questions. And then I kept a blog on the site where I could tell people what the call volumes were to expect for the next day. I could give them emerging news or issues like that one entity was maybe getting unusual calls and sharing the information with others. And then we did have a tracking set so we could track every patient's call and whether their concerns were resolved or not resolved, and that we had a third area of escalation to our compliance center. So really understanding, where you need to go to make sure you're tracking all the inputs and closing the loops with all of your patients. And then the final thing that we mentioned previously was making sure that that kind of syncing up your internal communications with your external communications.
That's great, Marcia, and thanks so much for sharing that and for fighting through the tickle in your throat. That's no fun at all. So in summary, as we're thinking about responding to adverse events, large-scale adverse events have similarities, but a lot of important differences from adverse events affecting individual patients. But we really should be using the same sort of CRP principles throughout. Early reporting, open communication, really extensive event analysis, financial resolution, care for the caregivers, etc. Proactivity, both in advance, and by that I mean starting to take these cases and think about how would our organization handle this. The more kind of advanced planning you can do, you can use this really as a stress test for your organization. That proactivity, both in advance and following the large-scale adverse event, is key. And I just wanted to highlight all of the tools and resources that are available now to support your large-scale adverse event response. There's a great toolkit on the CDC website. There are journal articles and a large-scale adverse event section in our resource library. And as you could tell from all of the comments, your colleagues have enormous expertise. And for these difficult problems, trying to work as a community to think through effective responses and support one another is great. So let's end there. I really appreciate everyone's participation, and I appreciated the feedback during the conversation. If you have any questions or want additional information, feel free to shoot us an email, and we'll look forward to seeing you again for the next webinar.
Thank you very much, and everyone, thank you for attending. And thank you to Ariadne Labs and the Collaborative for sponsoring Tom on this webinar. The materials and the recording will be posted at the Collaborative for Accountability Improvements website in the upcoming weeks. Thank you all very much and have a good day.